Today's discussion will be about ovarian cyst, workup and possible treatment options in our setup or in Somaliland. Ovarian cyst is one of the commonest diagnoses of disorders in reproductive human. It may account up to 15%. So when treating patient with ovarian cyst, the treatment principle or the treatment goal have 4 principles. So the first goal is to identify if this is malignancy, because malignant cysts have different management options and approach, and we need to treat the symptom, because most of the common symptoms is pain, so we need to treat the pain symptoms to preserve ovarian function when it's possible, and to minimize over treatment. We should not give treatment more than the required treatment. The first point is benign or malignant. To identify whether this cyst is benign or malignant, benign cysts can classify into two: neoplastic benign cysts like germ cell cysts, epithelial or sex-cord stromal tumors, and functional cysts, also some inflammatory. The commonest is functional, especially the follicular cyst. From the neoplastic cysts, the commonest is benign teratomas or germ cell tumors, especially benign major teratoma or dermoid cyst. The other thing of the malignant ovarian cysts or the malignant ovarian tumors have different classifications, but this one is the WHO classification, which is the 3 major classes are epithelial ovarian cancer, germ cell tumors, and sex-cord stromal tumor. The commonest is epithelial ovarian tumor. So to identify whether this is benign or malignant, we have different criteria or different things to use. For example, starting from the history to the investigations or the workup, we have different approaches or different points that we can categorize the cyst, whether it's benign or malignant. One of the easiest things that we can use in our setup is RMI, risk malignancy index score. So this scoring system have 3 components. These 3 components are the ultrasound and menopausal status and CA125. So menopausal status you will divide into 2, premenopause or postmenopause. You will give these scores if it's premenopause 1 or postmenopause 3. Then according to the features from the ultrasound, you will score accordingly. And the absolute level or the figure from CA125, then you will multiply all the 3 together. If it's more than 200, these things high likely may be malignant, so you need to work up as a malignant. The other thing we can use is IOTA, International Ovarian Tumor Analysis. This analysis is mostly used by radiologists. It has M features and P feature. M features are all features which are malignant, and P features are all features for benign, including all these things. For example, benign features include a unilocular cyst with thin-walled, clear content. If there is solid component, it should be very small component, less than 7 millimeter. The blood flow there should be no blood flow or should be minimal. While in malignance, you will find irregular tumor, high blood flow, exceptations. So the rules to classify this IOTA, rule 1 is when there is M feature, 1 or more M feature, and no P feature, you will classify as malignant. When there is no M feature but P features, you will classify as benign. And when you can't decide between benign and malignant, you need second stage testing or you need to retest. There are tumor markers that you can use. There are multiple tumor markers which are available in the country. But the tumor markers, especially those available in the country, include beta-HCG and CA125. Beta-HCG can tell you whether this ectopic mass is ectopic pregnancy or like carbos-luteum of pregnancy, germ cell neoplasms, ovarian choriocarcinoma, also mixed germ cell tumors, or embryonal cell carcinoma. CA125, it's produced by mesothelial cells that are lined into a peritoneum, pleura, and pericardial cavity. And it's mostly it's elevated in ovarian cancer, especially epithelial ovarian CA. It can be also elevated 1% in normal health women, and then malignant things can lead to rise of CA125 like myoma, endometriosis, adenomyosis, and salpingitis. But you can differentiate all these things from CA125. For example, if it's from malignant, due to malignancy, it will be high level, very high level in thousands or in hundreds, while the other things it may be mild elevation. The other markers we can do CEA, CA99, all these two are secreted from mucinous epithelial tumors. We have also serum alpha fetoprotein, serum AFP, it's elevated for endodermal sinus tumor or yolk sac tumors, and LDH from mostly related with breast germinoma. But the two things that we can do in the country is CA125 is our first. If you need another or you need to add some, you can add beta-HCG. So the management goal, as we identified before, you should identify whether this is malignant. So you will use that points to classify it as malignant or not. And for you go to treatment options, you have surgical treatment and then surgical treatment, and it depends on the size and the age of the patient and the diagnosis. So when we discuss the simple cyst, or the one cyst with benign qualities, divide into two, whether it's perimenopausal patient or postmenopausal. If it's perimenopausal and less than 3 cm or around 3 cm, it's normal anatomic finding. You should not consider it as abnormal. But if it's less than 5 cm, again, it needs no additional treatment is required. If it's from 5 to 7, then you need to repeat ultrasound 6 to 12 weeks, which is around maximum 3 months after. Then if it's, and you repeat into document resolution. If there's no resolution, then you can repeat transvaginal sonography yearly. If the diameter is more than 7 and sometimes more than 10 according to ACOG, you need to do MRI and surgical evaluation because the chance of malignancy will be increasing or high. If it's postmenopausal age, less than 1 centimeter in diameter is normal anatomic finding. Less than 5, you will do CA125, while in premenopausal, less than 5, you are not doing anything. But in postmenopause, around 5 or equal to 5 centimeter, you will do CA125. If it's normal, then you will repeat the transvaginal sonography 6 to 12 weeks later. If it persists, then you will repeat the ultrasound yearly. If it's more than 7 centimeter in diameter, you need MRI and surgical evaluation. The other treatment or the further treatment of the other cyst depends on the type of the cyst. For example, if it's hemorrhagic cyst in premenopausal age, less than 3, no need for anything because it's normal anatomic finding. If it's less than 5, no additional treatment. 5 to 7, you need to repeat the ultrasound 6 to 12 weeks. If it persists, then you will do MRI and surgical evaluation. Early postmenopausal age of any size with hemorrhagic cyst, prefer CA125. If it's normal, repeat the ultrasound 6 to 12 weeks later. If it persists or if the cyst is still there, then you should consider MRI and surgical evaluation. If it's late postmenopausal age of any size, then you need surgical evaluation. Other depends on the tumor size, the cyst diagnosis. For example, if it's endometrioma, you need to repeat only and monitor. Then every 6 to 12 weeks, first 6 to 12 weeks, then yearly. If it's mature cyst teratoma, you better remove it surgically. If it's not remove it, then yearly. And hydrosalpinx and the other para-ovarian cystis, it will be depends on the clinical condition of the patient. So the main message here is the cyst management depends on the size of the cyst and the age of the patient. And the finding from the tumor markers, you should also use the MRI, the RMI, risk malignancy index score, and IOTA classification. Then if you consider it benign, you will monitor. If you consider it malignant, then you will manage accordingly. But the other message that we need to tell the caregivers in the country who are treating the gynecological patient, you should not tell the patient different things. For example, some patients, some health professionals are telling the patient different information which is not true. For example, and in qofka lagu dhahdo tusaale ahaan cystigan meesha ku jirta ayaa keenaysa in ilmuhu soo dhaco ama cystigan meesha ku taala ayaa keenaysa in caadadu khalkhasho ama cystigan ayaa keenaysa inaanad u qaadin waxaasoo dhan iyagu aanay waxba ka jirin. The other thing is you should tell the patient that the treatment that you are giving, whether it is pills or if it's anti-pain, you should tell that this is not treating the cyst, but it's treating the symptom. Waayo ma jirto dawo aynu odhanayno cystiga ayay meesha ka saartaa. laakiin patient kasta wuxuu ku imanaysa oo kale cysti baan lahaa dawadaas la isiiyo uga baabiisay ama dawada la isiiyo way baabiin weyday dawo kale isiiyo uga baabiisa. The other message waxa weeyaan cystigu hadduu size-kiisu yar yahay 3 centimeter iyo wax ka yar waa inaanad qofka uga dhigin inuu xanuun jiro ama biyood iyo waxaas oo kale waayo waa normal physiological bad u tixgelinaysaa especially to the reproductive age women iska dumarka ku jira. That's all for today. Thank you.